Welcome to Empowered Voices, Recovery to Resiliency. In this episode, we're tackling an important topic that doesn't get enough compassionate, honest discussion: substance use during pregnancy. This is a subject often clouded by judgment and misconceptions. That's why we're bringing this up, so that we can have a lot of clarity from our medical expertise and personal experience. We'll explore the importance of prenatal care, understand the specific risk associated with substance use during pregnancy, and discuss how recovery journeys can begin at any point, even during pregnancy. That's actually where mine began.
That's right, yeah.
Yes.
So we have a guest today. We're thrilled to have, I'll get my biases out of the way first, but our special guest today is a maternal fetal medicine specialist, which is, the short of it is you are an obstetrician, but then you go to a fellowship to obtain more specialized levels of care, okay, for individuals. Dr. Manijeh, but goes by quote unquote MJ Kamyar. And here's where I'll give you my sort of, hopefully level the playing field. Same last name. And that's because she is my significant other. She is my spouse.
Beautiful wife.
Yeah, but, realistically, coming at this from that sort of level playing field, for this episode where we're talking about substance use specifically during pregnancy, prenatal care, what does that look like? We wanted to turn to experts. And so we opened it up to a lot of different experts in the state. And I'm just going to say that Dr. Kamyar is up there as one of the preeminent experts when it comes to high-risk pregnancies and substance use in the state. She works at High Risk Pregnancy Center, where they have the MOTHER program, stands for Maternal Opioid Treatment, Health, Education, and Recovery. Amani, you might be familiar with this one, but it's specifically a program for treating pregnant and postpartum individuals with an opioid use disorder. The way that program runs, it's really unique, vanguard, and it is the only program in the state that does what it does. Looking at co-occurring behavioral health issues. So if you might have co-occurring depression, anxiety, PTSD, for example, they will treat that. There's a therapy component, and then a big part of it is medications for an opioid use disorder, in addition to that obstetric and maternal fetal medicine / perinatology care. And I'll hand it over to Dr. Kamyar for her to give a little intro.
Welcome, and thank you for coming, Dr. Kamyar.
Thank you so much for having me. It's so nice to meet you, Amani, and I see this one every single day. So, and thanks for the warm welcome and the kind words. I just want to give a little background on where I work and kind of some more detail on what a maternal fetal medicine specialist is. So it's a mouthful, so we usually abbreviate it as MFM. So I'm an MFM specialist, and I work at the High Risk Pregnancy Center, like the other Dr. Kamyar here said. What we do typically is see patients who are both high risk and not high risk, but we see them for ultrasounds, we help manage medical problems, and included in that is substance use disorders. And so we treat all women who, or any pregnant person who is there and needs any of our help with regards to things like ultrasounds, lab work, managing, like I said, all their medical problems, and we try to do our best to do it in a really kind of non-judgmental and without stigma way. And I think that some of our specialized training allows us to do that, because we have seen thousands of patients with all kinds of medical problems, and it allows us to help those patients and do it in a way that hopefully resonates with them.
That's truly amazing. It's like all the things that we talk about on our episodes and whatnot, and things that we say we're going to talk about for future episodes, you can see that that's what you guys are practicing.
Yeah, and admittedly, you've heard me say this, that's my jam.
Yes.
So, perinatal mental health, reproductive psychiatry, those kinds of things. It's my jam. And I will admit, the reason it is my jam is because of MJ and her specialization within the world of OB and looking at that patient demographic. So that's what sparked my interest umpteen years ago. I'm not going to give away my age, but let's just say a lot of years ago. So there it is. Okay. All right. So let's dive in. We have you here. How about start us off with what does prenatal care look like for individuals that are high risk or using substances? And then how important is prenatal care for those individuals as well?
Yeah, good question. So, I want to say that when we're treating somebody with a substance use disorder, it's very similar to how we're treating someone with something like chronic hypertension or diabetes. So it involves things like ultrasounds. It involves things like consultations with an MFM specialist. It involves making sure that they're delivering at the right hospital, getting any pertinent lab work that needs to be done, any genetic testing that they desire. And it also involves things like monitoring baby, but then also monitoring mom for things like withdrawal symptoms. So, prenatal care is so important because what it allows us to do is to make sure that patients are getting the care that they need, that we're finding out if there's anything going on with baby that helps them determine, for example, where they need to deliver their baby, what special pediatricians they might need. And I think in general, access to care always improves outcomes. And starting that during that prenatal period can be really, really important.
Yeah. Is there anything that is different for, let's call it, regular prenatal care for your quote-unquote average patient, average pregnancy, compared to prenatal care for those that are high risk and sort of basically using substances?
Yeah, there's definitely a difference. So regular prenatal care, I would say, typically, let's say I'm going to give an example of a person who's 22 years old and has had one prior delivery that was full term, vaginal delivery, and that was their previous history. They're currently pregnant. Their prenatal care typically includes monthly visits with their general obstetrician, an ultrasound in the first trimester, an ultrasound at 20 weeks to look at baby's anatomy, and then the rest of the care is visits at their doctor's office. And then there's routine things like your routine prenatal labs, your glucose test that you have to do. Probably anyone who's been pregnant remembers that glucose test is
Yes.
not fun,
Yeah.
but it's very important. Yeah. And then typically more frequent visits towards the end of the pregnancy and then delivery at the hospital.
Yeah.
And usually in those cases, which hospital you decide to go to is, of course it's important, but not as important in the sense that, you don't have to have a specialized team or anything like that there at your delivery. Now we compare that to a high-risk pregnancy where you're getting your routine care here in Nevada. The way it typically is done is you're getting your routine care with your obstetrician, but in addition, you're seeing a high-risk specialist or an MFM physician. And what we're doing is regular ultrasounds more frequently than you would have if it was a more routine pregnancy. You're getting ultrasounds in the third trimester typically to check for baby's growth, because sometimes we will see some growth issues when we have substance use disorders. We're doing a little bit more fetal monitoring because we have some higher rates of some complications towards the end of the pregnancy that we're looking for. And you're getting a little bit more lab work done, and you're seeing some additional specialists typically a little bit more frequently. For example, a therapist, a behavioral health specialist. So we have a nurse practitioner in our office who takes care of our patients with any behavioral health needs. We have social workers. So yes, they'd be having some more interaction with some of those providers as well.
Okay, so it does sound like there's differences.
Absolutely.
Yes.
I want to turn to Amani, given that, Amani, if I'm understanding correctly, your pregnancy was involved substance exposure, correct?
Yes, my pregnancy with my daughter.
Yeah, and so technically that's a high-risk pregnancy.
Yes.
You've heard some of these differences that
Yes.
ideally occur
Yes.
during those exposed pregnancies. What was your experience like?
So it's funny that you mentioned that. When I was pregnant with my son, who's now 9, I was actually a high risk pregnancy. I carry the sickle cell trait as well, so I had to make sure I had the high risk experience with my son. Unfortunately, because I was using at the time of being pregnant with my daughter, that was the major barrier of me accessing care that I needed. And I tried to go to a lot of appointments, but also the guilt of using while being pregnant kept me from going to many appointments and being scared that, you just don't know what's going to happen. You know, you just don't know. You really don't. You think worst case, they're just going to basically, worst case, are they going to lock me up and keep me until because it's child abuse maybe, and keep me until I deliver and then take my child away. You just, you know, all the crazy things that go through your mind when you're using. And so I didn't attend a lot of my prenatal care. I know I was supposed to go to a high-risk pregnancy. The issue with that was the barriers with the high-risk pregnancy was I had transportation issues. I did not have an issue. The way that with my insurance setting up the rides at that time, the ride services weren't that reliable. I guess they pick up more than one person at a time. So if they're running late, and so with the high risk pregnancy, I probably should have told them my appointment was scheduled maybe an hour or two, but at the time they would call to verify when your appointments are. But you cannot be late at all, not even 15 minutes late, I guess at the high risk, because they had such a strict schedule. And the one that I was attending, every time I had my high risk pregnancy appointment, I was late. And the one time I was going to take a bus, I was late then too. So
yeah. Okay. So would you say though that in the limited, let's call it limited interactions that you did have, did you feel safe, and did you feel that the environment was non-judgmental?
Okay.
From the heart.
I've actually so I've actually switched quite a few OBGYNs during my pregnancy because I did feel judged.
Absolutely.
I felt like it was, you need to quit. You have a kid. What are you doing?
Yeah.
Stop. And it's like, I know I need to quit. I want to stop, but it's a lot harder than just
stopping.
It really is.
Yeah.
And so I did feel judged, and I would just switch. I would, and then first you would just not go. You would, of course, you would go use, and then you would switch or not go to your upcoming appointments. And then once you found another OBGYN, but I did find one that actually took the time, and she was the first one to really tell me to tear down. I'd never heard of that. I was like, what is a tear?
Yeah.
And so, and I was the first one. I'm like, you're not telling me to stop using. You're just telling me to use less, and you're telling me just to make sure I come in just so that you can make sure that things are going well with my child and everything. And she made me very comfortable to want to share my experiences and things that I was going through with her. It's kind of like a little therapy going on in that session. It made you feel loved and welcomed.
Right. So the human connection in a basic conversation was quote unquote therapy.
It was.
Wild, right? That we're talking being like that. However, you're not alone. We see this day in and day out, right? One of the biggest contributors to folks not obtaining what we're calling prenatal care: stigma,
yes,
judgment,
yes,
guilt,
yes,
shame. You fill in the blank, yeah.
Yes.
And one of the two, I would say, tied for kind of the two biggest concerns is what's going to happen from a legal standpoint, the individual themselves, and let's say something like Child Protective Services, their baby, and then the other is what's actually happening to my baby in utero, right?
Yes.
And there's so many different ways that this stuff can go. However, all of them come together. And unfortunately, this is super tragic, is most folks just don't feel comfortable obtaining that prenatal care. So they minimize it, or they just completely forego it. So turning to Dr. Kamyar, what are some ways that you all as professionals, how do you guys engage with patients in order to create those safe, non-judgmental environments?
Yeah. I just want to say thank you to Amani for sharing her story, because while it's your story, it's the story I hear over and over and over again. So, and I think that people don't realize that a lot of other pregnant people are going through the same thing, and they think they might be the only one, or and just sharing it is amazing. So thank you.
Thank you for helping.
Of course.
Us
So,
ladies, honestly, we need all the help and love we can get.
And while you were talking, I was thinking, okay, let's say you came to me, Amani, and you were pregnant, and you said, hey, I have diabetes, right? But I just can't. I can't stop eating that sugar. I just need some ice cream every day. I wouldn't sit here and just berate you for not giving up all of the sugar. I would say, okay, well, let's work on it, right? And that's how I would treat you for diabetes. And so it's kind of the same way I treat someone with a substance use disorder. So now we have to get back to your question, which I sort of forgot, but I think I remember, which is that, how do we...
But that's how are you creating safe, non-judgmental environments?
Absolutely.
And what I'm hearing is parity, equity, equality to other chronic medical health issues, which is what you exactly just described.
Right, because that's exactly what it is. And like I mentioned, the interventions are very similar across the board, whether you have hypertension, diabetes, or an opioid use disorder. A lot of those interventions with regards to ultrasounds, labs, monitoring are very similar. Okay. And so why would we not treat it the same way? You mentioned, for example, transportation and coming in late. The first thing I always ask a patient when they either have not shown up for multiple appointments or are late is the question, are you having a problem coming into the office? Not a problem with me, but are you having trouble getting into the office is kind of what I mean. Are you taking the bus? Are these appointments too early for you? Maybe you have a job where you work until 3 o'clock in the morning and then 8 a.m. appointments just aren't going to work for you, or maybe you have to take the bus, and et cetera, et cetera. So we really try in our office to understand and then try to help come up with solutions. So that's part of it, is just listening to the patient and saying, what is it that you need? Right? Do you need help with getting here? Do you need help with whatever it might be that is one of your barriers? What are you worried about? What are you scared of? Right? A lot of women hear some of these risks, and Amani, we had talked about this, saying that we're not trying to say that if some of these things happen that it was your fault, but that sometimes knowing about a condition, for example, let's say we're talking about you're at increased risk of preterm birth because of substance use disorders, right? Well, sometimes we can do things to identify if you're at highest risk and have interventions that can help prevent it. Or we can, admit you to the hospital, take care of you there, for example, right? Sorry, I'm going a little bit off track.
Yeah,
but, one of the other things you had mentioned is coming in late, right?
Yes.
We do see patients when they come in late. We try to figure out why they're late, like you said, transportation issues, but I don't like to have it be a barrier. You came to my office.
Yes.
You made it here. I'm going to take care of you. You might have to wait a little bit. It's okay. Other patients are here. They were here for their appointment on time. It's fine. But I'm going to see you today, even though you were late. Just because you're here and you showed up means you're interested in finding out what's going on and taking care of yourself and taking care of the baby.
I love that, only because I have to say, when I was running behind, I did not reach out to them because I figured they didn't want to hear my excuse. They did not want to hear my story. And now that I listen to you, I'm like, man, maybe I should have tried. So those listening who are suffering with the same issue I was going through, please reach out, because obviously there are people who want to hear and help you figure out and get rid of those barriers.
Yeah.
So heartwarming.
And
absolutely. I mean, we talk about, so this Empowered podcast, right? I mean, that's so much of what Empowered does, is trying to figure out what are those things that are preventing individuals from getting care. If it's transportation, let's get your transportation. If it's you are starving and you can't even think because you've got food insecurity, let's work on getting you food first. Don't get me started on housing.
Yes.
Oh my gosh. Okay.
Yeah.
All right. So I'm just going to give the one-liner, and then I want to talk about something that you had mentioned, Dr. Kamyar. The one-liner to me is, I guess, when we're dealing with individuals with a substance use disorder, but let's say individuals at large that are attempting to obtain prenatal care that is safe and non-judgmental, for all our clinicians out there, just start with treating them like you do any other patient that has a chronic medical issue.
Yes.
Period. Just start there, and we're probably going to make great headways to moving the needle. Okay. Now, you had mentioned some of those increased risks due to substance use during pregnancy. So before we get to having you go into that in detail, I want to try to balance the seriousness of the risks associated, okay, because we absolutely know that there are risks associated with substance use during pregnancy for the growing, right, fetus in utero. However, I'm trying to balance that for our viewers and our listeners to the scary nature that goes into then all these preconceived notions and those things that we talked about that might that might sort of scare individuals from obtaining care for whatever reason. All right. So for all of you that are listening and watching, please just take this with we're really looking at this from a medical perspective to provide you with the facts, to take it seriously, but ultimately know that there are things that we can do to assist and improve the health outcomes for both yourself and your baby. So get care. So get care. Okay, now handoff. So will you go through what are those risks associated with substance use during pregnancy?
The biggest things I would say are going to be things like congenital anomalies, preterm birth, other withdrawal symptoms in mom, slightly increased risks of things like stillbirth, and then needing specialized care after delivery. So we're talking about pregnancy, but then after delivery as well. And these things can exist, these risks exist when you're pregnant, period. Okay. Being pregnant, it's not necessarily, I'm not trying to be scary about it, but it has risk associated with it. Many of us who choose to have children choose to accept those risks, hoping that they don't occur, right? And what's important is not that your medical condition is causing these risks. That's not what's important. What's important is that, okay, you know that risk exists, and so you seek care to determine, do you have any of those specific things happening to you or your baby? And are there things we can do about it? Because that's where, when you get the care, it makes the difference. Yes, you're at risk for preterm birth, but there are things we can do to help prevent it. But I can only give you those things if you're in front of me, so that I can identify you as someone at risk, and I can say, hey, you need XYZ, right? Whether that's more ultrasounds or whether that's a medication or whatever it might be, more visits in my office, whatever. That's where the difference gets made.
Yeah. A lot of the focus is on opioids, for example. I would say stimulants as well, things like methamphetamine. Can you maybe give us some of the risks associated with those two classes of substances?
And some of the differences?
In particular, yeah.
With opiates, some of the bigger risks are going to be postnatal, so things, means after delivery, so neonatal withdrawal, okay? That's going to be one big one. But there are definitely increased risk during the pregnancy for things such as growth restriction and stillbirth. So that's with opiate use. With methamphetamine use or other stimulant use in general, we're going to have increased risks of things like preterm birth, hypertension in the patient, and things like placental abruption, which, if you haven't heard that word, it's just where the placenta separates from the uterus, but it increases the risk of preterm delivery, and a very in a sort of catastrophic way. So those are some of the differences there. And I know we're not really talking very much about alcohol, but alcohol use is another substance that gets used. Alcohol is another substance that gets used. And the main risks with that are things like fetal alcohol syndrome.
Yeah. And along those lines, you talked about, this is during pregnancy and a little bit after, I'm hearing, with some withdrawal symptoms for the newborn. Are there any sort of long-term risks for both the birthing individual and the newborn associated with substance use?
Yeah, so for the newborn, it's going to be things like behavioral or developmental kind of issues that you might not be able to identify at 1 month of life or 2 months of life, but might not show up until some of these later milestones are trying to be met, or when the child becomes of school-going age, right? Then we do see higher rates of things like issues with reading, for example, ADHD, other sorts of behavioral issues.
Yeah.
Okay. For the pregnant person, really the issues are going to be around kind of what happened at delivery and how things go postpartum. So, for example, if you're increased risk for preterm birth or placental abruption, then you have higher rates of things like C-section. So it's recovering from those and the potential, just risks associated with a surgical procedure. And then afterwards, especially this is more for if you're not getting treatment, it's going to be things like, continuing use, overdose, any of the associated complications from the mental health complications that can occur after, right? Things like postpartum depression and things that are at much higher rates for patients who have substance use disorders.
Yes. That's why Empowered's there.
Yeah, absolutely.
I didn't realize how serious it was until going into Empowered and wondering why they chose that specific, because I had friends who were that could use Empowered, but didn't have children or during that time frame period that we accept our clients. So I couldn't figure out why, but now knowing that it's very crucial and it's more postpartum than it is, that's where you really need that for sure care. It's not like, oh, you delivered and
see you later.
Pat your hands clean.
Right.
Yeah. Along those lines, that's what our evidence shows. Our evidence shows that the highest risk of, let's call it, morbidity and mortality, mortality being death, aka maternal mortality, actually occurs in the first year postpartum, not during pregnancy, but in that first year postpartum. And it's a combination of reasons, but that notion, Amani, is exactly why we think there's a large contributing factor, is this sense of, you delivered, you're good to go.
Yeah.
We got you through the tough spot. See you later, alligator, good luck. And that is not at all the case.
Yes.
When I sort of approach things, or when you look at things from a mental health perspective, which let's remind everyone that substance use falls within the umbrella of mental health. Yeah. Yes. Pregnancy can be a very tumultuous time for individuals in the lifespan of their behavioral health or mental health issue. What do I mean by that? I mean, I'm an individual who has major depressive disorder. I've been treated for 20 years. Everything was perfectly fine. It was well controlled, stable. I got pregnant. Nothing else changed. And all hell broke loose. Tumultuous time. Okay, now you ready? You go to postpartum, and it's take it up a notch. So it's that same individual, I got pregnant, everything was totally fine still during pregnancy, but then I delivered and all hell broke loose. So now you take these, compound them with a substance use disorder, and I guess we have some of the explanation as to why, right? So for our clinicians out there, for our viewers and our listeners, please, 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 please do not forget about the postpartum period as being a super important time to continue or establish care or start
I was going to say,
care.
even if you didn't get
It's not
prenatal
too
care,
late.
even if you didn't get prenatal care, you can get postnatal care.
You can get
you
postnatal
can
care.
get care after your delivery, and you should seek it, definitely.
Now, I do have a question for you, for people who wouldn't know, like myself. When you say postnatal care, would that be with your primary care, or would that still be with an OBGYN?
Yeah, it depends on the time period.
Gotcha.
So typically after you deliver, if you're within that 6 to 8 week postpartum time frame, absolutely go see your obstetrician.
Gotcha.
Right? And if let's say you didn't have one and you delivered at a hospital and without prenatal care, usually, almost always, they should give you a postpartum appointment with someone, or say, here's a phone number you can call to get a postpartum appointment. Take advantage of that, right?
Okay.
I want people to take advantage of that. And let's say you can't get to an OB for some reason, it just doesn't work. You're going to probably take your baby to a pediatrician. Talk to that pediatrician. Ask them. Say, hey, I delivered and I'm having a hard time. Pediatricians take a lot of care of postpartum women because you bring your baby in more often than you go in.
That
Do
is,
you remember that?
No,
I mean,
my daughter
Yes.
had every doctor's appointment.
right. You're like, I'm not taking care of myself,
Yes.
but I am going to take this baby to the
Yes.
pediatrician, right?
Yes.
By hook or by crook, we are getting there. Okay, so
She's gonna be all right.
She's going to be all right because I'm going to take her to all of those appointments. But these pediatricians hear it all from the mom, so they have. I'm not trying to put work on a pediatrician, but what I'm trying to say is they can usually help guide you in a
Yes.
direction. Okay, so don't think that just because that's not your doctor that you can't ask them those questions. And then let's say you can't get to any of those people, but you have a primary care doctor. Yes, reach out to them. Especially if it's somebody that you've known for a while or trust.
That's so awesome. I have to say, I had a really close relationship with what I mean by close was they actually took the time to care, not like we were hanging out or anything, but they actually so I felt like we developed a close relationship with my son's pediatrician, and I would tell him how I was feeling, you know, how mom was doing, and he would actually give me resources. Who knew? He would give me resources to behavioral places. He knew how I felt. I really didn't like giving my child medicine, so he would try the best that he could without and say, "Okay, Amani, we're gonna have to do this," you know. But he took his time to explain things, and he just, like you said, pediatricians, yes,
Well, it sounds like he listened.
yes.
He met you where you were at.
Yes.
Maybe as a new mom, feeling like uncomfortable about the medical whatever field and not sure if they're doing the right thing for your child. But because he listened and made some kind of concessions or adjustments to the way he would normally practice, when he did recommend, "Hey, Amani, you've got to give your child this medication," you probably said, okay. He's
Without
being
a doubt.
serious, right?
Without a doubt.
Because
Without a
he's
doubt.
listened to me this whole time and we've had a good rapport. And now
Yes.
he's saying, "You've got to do this." And you listened because you trusted that he was actually telling you the right thing.
Yes, it is true.
Sounds like that was a safe, non-judgmental
Yeah.
It was.
environment.
And
yeah.
now, like, hearing you speak, I just think about just my journey, just in motherhood in general, and my two different experiences.
And your two different experiences. Yeah. I mean, that's sort of hitting back at the significant barriers to care, sort of how do we overcome them. We touched on some of those points about stigma.
Yes.
There's lots of stigma, self and sort of external, the guilt, the shame, the judgment,
Yes.
all those kinds of things. So I'm glad that at least at some point during your care, Dr. Kamyar, you had mentioned this or postnatal. It was in reference to when should you start care. Let's go back though to pregnancy. We in the industry, we kind of refer to pregnancy as an ideal window of opportunity to have folks engage in sort of AKA treatment or begin their road to recovery. Tell us about why pregnancy is a really good time to think about that.
So it tends to be a time when people have something other than themselves to think about. And sometimes, even though we might know that using a certain substance isn't good for us,
Yes.
when we're pregnant, we think, well, but now I have to think about something else. Now, I'm a big believer, and you should do it for yourself as well. But if that's not enough of a motivation for you, or it just hasn't been in the past, oftentimes pregnancy is a time when, number one, people decide, I'm going to actually go see a doctor.
Yes.
And number two, they're motivated because they have this, even though it's internal, this external thing that's making them feel like, I want to make a change in my life. Many people who are pregnant decide to make other types of changes. They change their diet drastically because they're pregnant. Oh, I'm not going to drink caffeine anymore. Yeah,
You're right.
I'm going to be super healthy. I'm only going to eat fruits and vegetables and call it a day. They make those big changes. And so it makes a lot of sense, right? That when you're pregnant, you also, if you're using any substances, think, maybe this is the time that I need to not do that. So that is a huge, I think, window of opportunity that we as providers like to sort of take advantage of, even though I don't like that saying take advantage, but, in a good way, right?
Yes.
Take advantage of that because
Seize the moment.
yes, seize the moment. But one of the only ways you're going to be able to do it is if your patient tells you
Yes.
about their use, or if you ask.
Yes. Like you say, screening.
Right.
Screening.
We've talked about.
Screening.
See, I know what he likes, right?
Screening.
I know what he likes to hear. So no, I'm just kidding, but it's true. Screening, right? Because if you don't ask someone, you're never going to know, and some people aren't going to share that information.
No, you're right.
And you have to ask the right questions, and sometimes you don't even necessarily get the information when you ask about them. You find out the information when you ask about your partner or your family, and then it leads to conversation that makes that patient feel comfortable.
Yes.
That, hey, this is someone who, they heard about my mom using and they were fine with it. Maybe they're going to be okay hearing about me using.
Yes.
Yeah. Amani, did that influence you at all for your road to recovery and your experience when you were most recently pregnant? This sort of motivation that now I'm pregnant. I really should, those kinds of things. Just like, sort of walk us through what it looked like for you.
So, yes, that was a big motivation for me. Prior to me becoming pregnant, I was in my head on my way to recovery. I knew I wanted to stop using. I knew I had to stop. It wasn't anymore, but I just couldn't. So I was in my head on my way, but once I did find out I was pregnant, I still had my relapses and whatnot, but I did quit, and I was abstinent, especially my last trimester for sure. I did not use because I didn't want my kid to have any of the complications that you say. And then you go online, you read it, it's 10 times. Well, granted, these are worst case scenarios that are being presented, and these are real things that do happen. But sometimes we can flood our brains with certain things that, can just go to the deep end.
Sure.
So, yeah.
So, yeah. Okay.
And sorry, you had asked about sort of where we had kind of touched upon timing of getting this care.
Yeah, timing.
So there's no wrong time to get the care. Some people think, well, I didn't start in the beginning, so I'm not even going to bother.
I thought that too.
What's the point now? I'm 30 weeks pregnant. I'll just have a baby and call it a day. But it matters. Even if you are 39 weeks and 6 days and your due date is tomorrow and you come to my office, I think that makes a difference. And it makes a difference because you reached out, you initiated that, you wanted to get some care, and then it just opens that door for all the postpartum stuff that we talked about, right? Yeah. So there is no wrong time. Any time during your journey is fine. You haven't passed anything. Maybe you can't do your glucose test anymore. It's fine. We're just do the next test that we can do. Maybe you can't get XYZ lab drawn. That's fine. We'll just do what we can do. We'll do what's appropriate for the time that you're at, and that's okay.
Yeah, and to continue along that line, you included previously, even in the postpartum period.
Yes.
It doesn't need to just only be
That's
during
right.
pregnancy or you're done. We talked about the risks associated mostly, right?
Yes.
More deaths occur in the postpartum period. So it really does hit on that sort of any time. And look, we live in a world of powerful synthetic substances.
Yes.
Okay. Fentanyl gets all the attention now, but who knows what's coming down the line. There's a substance called carfentanil, which is 100 times more potent than fentanyl, which makes it 10,000 times more potent than morphine. Okay? So, yeah. But we live in the age where these exist. And that can happen at any given time. So to engage in and sort of, I'm going to, is usually universally better than never.
Yeah.
Yes.
Than never.
I loved how you said even if you're at 39 weeks to go in, because a lot of the times I didn't know this, but your postnatal care, I didn't know really much about postnatal care. I just saw a primary care doctor, but I just want to make sure that all the ladies who are listening who are pregnant, please receive postnatal care. It's very important. It's super important, vital, and seek care at any time.
At any time.
It's it's crazy, right? We think about, okay, we want everything for our baby. You're saying you took your baby to the pediatrician. If they said you got to come every day, you would have done it, right, Amani?
Most definitely. On the bus early, at 2 o'clock in the morning.
Whatever you need, right. But you're the one taking care of your baby.
Yes.
And so how are you going to do that if you're not well? I know. I'm not saying this is not me, but I'm saying that because
but it's true.
You being well is just as important for your child's health as your child's being well. So they both matter.
Yes.
I sometimes really don't like the focus that people, providers, specifically doctors, put on the baby. Because it's not just about the baby.
Yes.
It's about the mom, right? It's about the person who is pregnant. That's who it's also about. Yes. And I'd say that's who it's about first. And then it's also about the baby. Yes. We can't have a healthy childhood if we don't have a healthy guardian who's caring for us.
Yeah, and through, this is what our evidence supports. So me as a mental health specialist, this is why it's so important to treat mental health issues, including substance use disorder, in that individual, right? In the birthing parent, in that guardian, that caregiver, because we do see it from an evidentiary standpoint. Your ability to parent, to caregive, to bond, to fill in the blank, again, is umpteen times better outcome for yourself, and then better outcome for your infant, your child, your toddler. And now we start to get into generational. I can talk about this for a whole nother episode, right? But it is absolutely important, because when we talk about recovery, it's about being able to live the life that you want to live. Yes. And for most parents, living the life that they want to live is being able to provide the best for their child, to caregive the best for their child, to give the best environment for their child. Yes. And we see the ramifications of those as being an improved life for the child directly right then and there, but also generationally down the line and for their offspring. Cool. All right, look, we're running out of time, but one thing that I really, really, really want to get to, because it's ultra important, not that everything else wasn't, but when we're looking at substance use disorder during pregnancy, let's focus maybe a little bit on something like opioid use disorder. What are treatment options during pregnancy?
Yeah, so the good thing about opioid use disorder is that there is some treatment. There is some treatment for it. So we can give patients something called buprenorphine to help manage their withdrawal symptoms and help prevent cravings, and to sort of allow for treatment that leads to better pregnancy outcomes and outcomes for the baby. So one of the best things about opioid use disorder is that there is this treatment. In comparison to, and this doesn't mean that you shouldn't seek help with other substance uses, but there isn't this type of medication for methamphetamine use, for example. So instead, for methamphetamine use, we do other things, right? Therapy, working on decreasing use, et cetera, like you talked about with your provider that you had that did the right thing for you. So yes, for opioid use disorder, there is treatment, and that treatment is safe for use in pregnancy.
Yes. Along those lines, so some clarification. There are effective treatments for any use disorder, including methamphetamine, stimulants, nicotine, alcohol. You take your pick of the substance. But particularly when it comes to opioids, I am also very grateful that we have what we call life-saving medications, known as medications for opioid use disorder. Currently, there are 3 FDA-approved medications. Methadone, the most commonly used during pregnancy, and probably most well-known because it's been around the longest. Then we have buprenorphine and naltrexone. These medications are generally safe to use during pregnancy. However, I want to add that there are superior medications. There's 3 of them. There are those that are superior.
I'm sorry, I focused on what I think, what is evidence-based to be the most superior one, which is the one which is what we're bringing up.
Yeah, exactly. And that's the one that Dr. Kamyar mentioned, which is buprenorphine. So currently, all the guidelines recommend using either methadone or buprenorphine as first line. However, over the past 20 years, the preponderance of evidence, that means most of, if not all, the evidence shows that the superior medication is buprenorphine. Why? Multifold. congenital anomalies compared to methadone, risk of overdose, risk of other drug interactions, monitoring, being able to obtain it in an office like high-risk pregnancy center. So folks can go in and get all the rest of their care and be prescribed buprenorphine. Methadone is very strictly regulated federal. You have to go to a federally qualified opioid treatment program. And when you're starting treatment, it's every day. It's every day you're going in and getting dosed. So, and that's all on, like, let's call it birthing individual side. Then you have the neonates. Through and through, neonatal abstinence withdrawal syndrome is less in every which way, and outcomes appear to be superior for the neonate. Larger birth weights, less risk of prematurity, larger head circumference, which is brain, right? And lower risk, severity, and duration of NAS. So we have a huge push here in Nevada to get individuals to think buprenorphine first line. Okay, buprenorphine first line during pregnancy because of all these favorable factors. Now, told you about a third one, which is called naltrexone. In 5 years, maybe when we do a redo of this episode, okay, I'm hoping that we're talking about that guideline, including now naltrexone. Won't get into it now because there's not enough time, but naltrexone is basically long-acting naloxone, aka Narcan, which is a total opioid blocker, and the neonates have no risk of withdrawal or minimal to none. So that's leading edge. We're really the only place that offers naltrexone during pregnancy, but other than that, it's not being used. So that's why, Amani, my focus was on buprenorphine because we're really looking at those two. So there it is. There's the big message I wanted to sort of get across. Buprenorphine. It is safe. It is life-saving. It oftentimes is the make it or break it for individuals.
Could you touch on one thing that sometimes patients bring up? And maybe you can have something that you say to your patients who say this, which is, feeling like a buprenorphine isn't good enough. They need to be off of everything, right?
Yeah.
So
Sure.
what do you, because I have something that I tell patients, which is that, they're getting treatment with something that is working. It's life altering. It is allowing them to have a healthier pregnancy and then after delivery to have a healthier life, right? And there's no reason to even be worried about or thinking about being off of that medication during pregnancy. What do you?
Yeah, so from that risk-benefit analysis, right, fundamentally when we're dealing with individuals who are using substances, let's say they're using illicit, whatever it may be, which nowadays is adulterated and contains fentanyl, right? The majority of the drug supply now contains, the illicit drug supply contains fentanyl, okay? So then the conversation becomes, if you are going to be using, do you prefer having your neonate exposed to substance unknown, and fentanyl, or buprenorphine? So there's one, right? The other is the stat. This is the stat that I use for all the individuals that I see who ask me, how long do I have to be on this medication? Say, one, for however long it works for you, okay? How about that to be a goal? But on my end of things, if I could choose a minimum duration for you, it would be a year.
Really?
Why a year? Our studies show that folks, and this is for opioid use disorder because we do have those medications, for folks that go quote unquote abstinence-based, but let's call it non-medication-based treatment, for individuals that their duration of treatment is less than a year, the return to use, aka relapse rate, is effectively 100%. It's in the 90th percentiles, right?
Wow.
And that means most individuals return to use. So that's why I shoot for a year
that makes
as sort of
sense.
that. And so then we start to talk about pregnancy, short period of time, but then a lot of risk of overdose in the first year postpartum. My conversation for pregnancy becomes, can you give me that first year postpartum? And here's all the reasons why. However, patient-centered care means I have to give you proper informed consent and you get to make the decisions, okay? I am there as your navigator and to provide you my knowledge and experience, right? However, ultimately, the individual needs to sign off on that and say, yes, this plan sounds amenable. For those that want to be off of everything prior to delivery, I say, let's do it if we can.
Yes.
And if we can do it safely, because we do have individuals where they're able to get stabilized on, they're using illicit fentanyl and OxyContin off the streets. We get them stabilized on buprenorphine. They no cravings, no withdrawals. They are living the life that they want to live. Okay, so they're in remission and in active recovery. Okay. We can start to scale back the amount of medication that they're on with close monitoring all along the way, and with all the other things required, not required, but beneficial to someone's road to recovery that we've talked about in depth. Wellness, support systems.
Yes.
What does this look
Tool
like?
belt.
Social determinants of health. When a lot of those other things are in play, people can be successful.
Yes.
And so they slowly, you talked about it, sort of tapering off to maybe discontinuing.
Yes.
For some individuals that works, for other individuals it doesn't, okay? But for those where they are able to, in addition to continuing everything else that's going on in their life and working for them, they're off medication, and then the risks to their neonate at the time of delivery in regards to neonatal abstinence syndrome or withdrawal basically diminishes. I will never say zero, because there has been exposure during pregnancy. So I cannot predict with absolute certainty that there will be zero, but it drastically reduces. And then the caveat is, okay, cool, we got you through pregnancy.
But we're going to
Let's-
still follow you
Yes.
But we're still going to follow
postpartum.
you postpartum, because
Right.
if anything happens, this is the highest risk time. If we need to go back to something like buprenorphine, let's do it.
Yeah.
Doors open, 24/7, rock and
Love
roll.
it.
Right.
Because ultimately, go back to this. We are living in an age of powerful substances where you can overdose like that.
No,
If you
literally.
overdose and you're gone, now all those dreams that you had of being a parent, caregiver
Gone.
to
It's
this
gone.
newborn
Gone.
are gone.
Yeah.
So let's end with that. Any parting thoughts, Dr. Kamyar?
I mean, I think that was great. One of the things that I wanted to say that I thought Amani did so well when she was pregnant, which is that she didn't give up. She didn't have providers that she initially thought were supportive, and she kept trying and kept trying. And I think that shows so much resilience and strength. And I hope that all of our pregnant patients can have some of that, because I know it can be really hard. I just don't want people to give up if they've had one or two or even three or four
Yes.
bad experiences, because I think especially here in Nevada, but hopefully everywhere, you can find a provider who is willing to be the right one for you. You just
Yes.
sometimes have to give it a little bit more of a try.
Yes.
Yeah.
When they
I
say
don't want people to give up.
Yes, it's hard sometimes, and it's hard, especially when you're discouraged, and then it's hard when you're not thinking with a full deck to give up. But keep going, keep going, keep going, and like you said, I love it. Is seek care at any time, and the best. The most important time actually is after delivery, is
There
what
you
I'm
go.
starting to find out.
There you go. Learn something new
Every
day. Yeah. Well, thanks so much. Thanks so much for joining
so
us.
Thank you for
much,
having me.
Dr. Kamyar, for coming.
Thank you for having me.
Thank you for enlightening us, or me especially.
Thank you for listening or watching this episode of Empowered Voices. Rate and share with others who may find our information and discussion topics helpful. Finally, if you visit our website, empoweredmoms.org/podcasts, you can share your thoughts, ask questions, or suggest topics to be discussed in upcoming episodes. On behalf of Amani and our entire podcast team, thank you for joining us.